and we spoke about the timing on the VV ECMO in hypoxemic respiratory failure. So, what exactly the timing means? One is, of course, as you talk about, is it the initiation of ECMO early versus late, or do we also have to think about whether it's a referral timing or it's a cannulation timing? What exactly we talk about this, because it varies from person to person. If I think about the timing now, and my unit doesn't have an ECMO per se, so of course to organize things will take 4 to 5 hours in a situation. So those two are very different situation, and we need to make our audience understand what exactly the timing of initiation of ECMO means and what exactly the timing of the referral to the ECMO centers means.
Yeah, I think it's an important concept to understand, Bharat, because we all accept that not all our ICUs are resourced enough and have ECMO machines. So when you have such a situation and you have to refer patients, your criteria for referral will be much early. The decision of going on ECMO eventually lies with the center that offers ECMO. So their criteria for going on ECMO will be slightly different. Now that part is easier to define because the EOLIA criteria has laid it down very nicely. So PF ratio less than 80 and all those stuff. So any ECMO center, if you talk to them, initiating ECMO, I would do that if they satisfy this EOLIA criteria. Now, the question of referral to ECMO can be quite variable. And that's where, most of the times we figure out that it could have been referred early or to me, the way I look at it is
Because even we see this, because many people take that Eulia trial to be as referred as well. So by the time we are contacted, it's already we will of course will take 3 4 hours to mobilize things to get the patient. So we are late.
True. That is exactly what is happening. So I go through the same problem here in Singapore as well. Essentially, our peripheral centers who refer to us, we had educational sessions with them to tell them that the EOLIA criteria is for us to follow, for you to follow. I would suggest calling me when your patient is prone positioned. So as soon as the PROSIVA conditions are met and you are prone positioning your patient, you give the ECMO center a call and tell them that, hey guys, here I have a patient who's been prone positioned. I don't know what it's going to be, but at least, I'm keeping you in the loop. I think the onus will then be on the ECMO center to follow it up. That will be a good model to emulate, where ECMO center then keeps following up with you on when we should go on ECMO. And I think at that point, the discussions, deliberations can revolve around how much you want to push the EOLIA criteria and how much or what will be the ideal time for the team to come over to cannulate. So you rightly pointed out the EOLIA trial essentially gives you the timing of cannulation in an ECMO center. Outside of it, the referral criteria should be early. To me, as early as when the patient gets prone positioned.
Yes. So that's nice you're putting it. As soon as we prone the patient to have the ECMO guys in loop, and if patient improves, of course, then it's a good thing.
Yeah.
If it doesn't, yeah, then we know when to intervene and get the patient to the ECMO centers.
True.
So
the only therapeutic conundrum that happens when your patient is prone position and is referred is the patients who respond and who do not respond to prone positioning. So the patients who do not respond to prone positioning, clear-cut candidates for ECMO. Then there are a group of patients who would respond to proning. They are not candidates for ECMO. There is also a third group who would partially respond to prone positioning. So every time you prone position them, PO2 PF ratio is about 100, 110. They would not satisfy the EOLIA criteria. And clearly, referral centers, at least here, they get impatient by day 4, day 5, when this is happening on a regular basis. So I think that group is a bit tricky to manage. But even then, you still give the benefit of doubt, at least 4 proning sessions, 4 to 6 proning sessions, and your PO2s are, fixed at somewhere 100, 110, 120. You still offer them ECMO. Yeah.
Usually they don't do well. Moment you make them supine, they will further go down.
Yes, that's the classic group which
yes, well, that's what. So now, before we set the stage for the trial, so we just want to understand for the audience what's the basic physiological rationale for early ECMO. Is it just about the oxygenation or the lung rest, or we reduce the plateau pressure, driving pressure? What exactly works over here?
Okay, I'll take you through the process of ECMO initiation so that this can be explained better. The process of ECMO initiation involves not just putting in huge pipes. So the huge pipes essentially take blood out of the body, pass it through an artificial heart, which is a centrifugal pump, and pass it through a membrane lung, which is the artificial lung, oxygenate it, remove the carbon dioxide, and then send back this blood back to the body. So that's what ECMO does. Now, it's not just confined to gas exchange. What you essentially do in that process is when you are able to do gas exchange outside the body, you can very well rest the organ well inside. So it's like having a cut in your arm, and you don't mobilize that part of the arm quite frequently, your healing will be faster.
Allow it to rest so that healing is faster.
Exactly. So while we go on ECMO and improve gas exchange, side by side, we cut down the ventilator parameters such that we offer only 1 to 2 mils per kg of tidal volume, ultra low volume tidal volume ventilation with minimal lung injury. But, we still give them a PEEP of anywhere between 10 to 12 to keep the alveoli open. And we await lung recovery. Now, this recovery can be long, especially in respiratory ECMO. With viral pneumonias, it's about a week to 10 days. With bacterial pneumonia, it's up to 3 to 4 weeks. And sometimes you get complicated pneumonias where you have to run it for more than 6 weeks.